Got 45, 46 online and 48 and growing.
Okay.
The time is, it is 12 o'clock. So welcome everybody to our weekly grand rounds. This will be the second to last grand rounds of the year. Next week's grand rounds will be the last for the year. We're very fortunate today to have Dr. Guillermo Rocha from Brandon, Manitoba, as our guest speaker, and he will be formally introduced after the case presentations. So without any further ado, we're going to start with Dr. Yellen Yang, who's going to present our first case. Yellen?
Yeah, so thank you for the introduction. So the title of my case is called Recurrent Problems, and special thank you to Dr. Rootman and Dr. Slomovic for their help with this case. Just a disclaimer before we start that unfortunately due to COVID, we did not have access to part of patient's file. So we've used clinical photos that are similar to the patient, but the topography is his own. So we have a 48-year-old male referred from another ophthalmologist. He's had a history of recurring corneal erosions with epithelial basement membrane dystrophy. He had superficial keratectomy with diamond burr and anterior stromal puncture in both eyes a few months ago. He's also had a history of remote PRK, and he is now a mild myope. So the patient says there's been no more recurrences. However, the vision in the left eye has been blurry since the procedure. So on exam, his vision was 2200, and you can see dense central stromal scarring. He also had peripheral scarring from the stromal puncture. The referring doctor tried a course of steroids, however, there was no improvement. So this is the patient's topography, and you can see mild central flattening, and this is more obvious on the instantaneous map with this peripheral red ring. So this is likely from the previous myopic ablation. So we have a patient with corneal haze, non-responsive to topical steroids. So what's your next step?
Should we be jumping in or?
So, yeah, sure, Josh, go ahead.
Oh yeah, sure. So I guess you started off, with the topical steroids, which would be my first treatment as well. Of course, making sure there's no other causes of inflammation. So making sure there's no MGD, making sure they're lubricated, etc. I find steroids work best early on. I think later on, when you have a formed scar, steroids don't work that well. Scars in and of themselves do usually fade with time, but only to a certain extent. So just time. And lastly, if I have someone that really wants something done, I usually do a trial of serum tears. I'll be honest when I say I have been underwhelmed with them, especially late. If steroids don't work, I don't think they've really worked very well. But certainly, like as medical treatment goes, on top of steroids, I think serum tears can be added. And then we would go to other options, but I don't know if we want to get that far yet. So I don't want to jump ahead.
Mm-hmm. I'd like to comment a little bit on how we got here. I think one of the important things in terms of managing people with recurrent corneal erosions is, as you mentioned, Josh, right now, making sure we're dealing with the ocular surface. And someone who's having recurrent corneal erosions, I think needs to have very, very intense treatment. I usually place them on doxycycline as well, and lid hygiene, tea tree oil, all of that. Once you start managing, one of the things I like to tell patients is, you have a recurrent corneal erosion, you're not going to live like this for the rest of your life. In fact, just right now, I did a superficial keratectomy in the office here for a similar case. But I think I've gone away from diamond burr, and I wonder if that may be a contributing factor in this particular case. Now, what would I do at this point, now that you're asking for options? I think the first thing is optimizing the ocular surface. Topical steroids, I also agree, may not do much. And at this point, one step would be simply to wait a little bit before we do any more things. And I'm sure there will be other options, but waiting, it doesn't hurt really. And it often sort of allows for some clearing of this type of haze.
Let me ask you a question, and this is really directed to all of the cornea staff. How often do you see haze after doing a superficial keratectomy for epithelial basement membrane dystrophy leading to recurrent erosion? And do you think the PRK may have been a contributor to this? Guillermo?
How far away was the PRK?
It was very remote. I don't know the exact timing, but it was years ago.
Mm-hmm. Yeah, I mean, it's hard to say if it was years ago. It depends on what type of ocular surface, how well the ocular surface or how healthy the ocular surface was. I also think that if the diamond burr debridement was a little bit deeper and creating other issues, it might have been the trigger. I can't really say whether it was the PRK or not, but I would be more concerned probably about the diamond burr.
Let's say, putting aside PRK, for the average person who's doing superficial keratectomy for epithelial basement membrane dystrophy, you don't go very deep. Mm-hmm. So I personally have not seen that, mm-hmm. That I recall in terms of getting haze. I mean, have you seen that?
I haven't. I mean, you're usually on Bauman's, right? And the way I do it, my initial approach would be as simple as just taking a cotton tip applicator. But I often, if it recurs, I will actually use an Amoyles brush and really polish that area very nicely, all the way out to the to any of the loose epithelium. But you're absolutely right. I mean, I don't recall seeing much in terms of haze with that. So I mean, perhaps what you're driving at is that the disruption of Bauman's layer may be a contributing factor.
Possibly. Yellen? Okay,
great. So because our patient has significant decrease in vision, he was non-responsive to topical steroids, we discussed a few options with him, including repeating the debridement, PTK, and possibly using MMC on top of this. So maybe we can launch the poll at this point. So what would be your step on managing corneal haze, non-responsive to steroids, out of these options? Maybe just 5 more seconds.
Sure, yeah, I'll give it a couple more seconds. The votes are starting to come in there.
Sure, yeah, thanks.
Oh, someone ended it. Okay.
Okay, perfect. So most people picked repeat debridement with MMC. So our patient actually went on to have PTK with MMC. He did very well post-op and the vision improved to 20/40 at one point. However, he returned a few months later saying that his vision was hazy and he felt unbalanced. So you can see that the vision is now 2100 pinholes to 20/30. He did have mild central haze on exam, but this was much improved compared to initial exam. This is his topography. You can see there's a slight increase in the central flattening. So we obtained his refraction, and you can see he had significant anisometropia. So in the right eye, he was still myopic. However, in the left eye, he is now hyperopic with astigmatism. So our patient has developed a hyperopic shift from the PTK. And this is actually very common. It's been reported in up to 50% of eyes after treatment for recurrent corneal erosions. And this figure is likely even higher for scarring. So we discussed a few options with our patient to manage the anisometropia, including glasses, contact lenses, topography-guided PRK, and cataract surgery. Unfortunately, our patient did not tolerate glasses and contact lenses, so he went on to have cataract surgery and PRK with good results.
Yellen, I just want to make a comment about if you can go back to the previous slide, that one, one more there, the hyperopic shift. So this also. This is certainly true when you're dealing with this kind of like a broad beam laser and a single application, and it depends on the laser. For example, the Vizix, if you do a PTK mode, you will induce a flattening that will cause hyperopic shift. There are other lasers that can cause a myopic shift slightly, and I believe the Wavelight does that. And then the Schwind laser actually has a feature where you can flatten and then steepen at the same time. So you can almost do a neutral PTK. So it's also important to know which laser you would be using to try to attempt the PTK, or how you're going to compensate for that.
That's a good point. In fact, you know, I know with the, I'm not doing refractive surgery anymore, but when I was, and we do a PTK, even now when I do a PTK, we still add like a diopter of hyperopia treatment at the end. That's a guesstimation. Do we know how deep we went with the PTK? How many microns were ablated? And did we go through epithelium or did we debride the epithelium? What was the process here?
Right, so unfortunately this part of the file we could not access because of COVID. It was done at a private surgical center.
Okay. Okay.
That's
And I think, Alan, that's an important point, because if you're trying to eliminate an irregular surface and then control the potential response with the mitomycin, if you're using laser ablation or laser scrape, so to speak, you're using your own epithelium or the patient's epithelium as a masking agent to produce a more regular surface.
So if I could just pipe up there for a second, if I remember correctly, I'm relying on my memory here, but I'm pretty sure we did a TCAT PRK with transepithelial removal of the epithelium. So using the epithelium as a masking agent, since that was the surface, our initial surface to deal with, because there was quite a bit of irregular astigmatism from this scarring. So I don't remember how deep it went, but that's my recollection. It wasn't just a straight PRK like on the Vizx. It was done on the Allegretto in the topo guided mode.
And I would also say, obviously his PRK seems to have either regressed or he's become more myopic with age, or he's got early cataracts or something. But a 5 diopter, I cannot imagine that there was truly a 5 diopter hyperopic change from the PTK. And I assume a lot of this is probably from the initial scarring, right? You got to assume that.
I mean, that's a great point. You got to imagine if this person had PRK and the right eye, which was not touched, is a -325, there was significant regression. And possibly that, we know that regression many times is associated with scar formation. Do we know if the right eye was clear, Yellen?
As far as I know, it was clear.
Okay.
Okay, go on. So just briefly on recurrent corneal erosions. So this is thought to occur likely due to poor adhesions of epithelium and likely from abnormal hemidesmal zones. So in the acute period, lubricating antibiotic drops are used, and hypertonic saline can be used as the epithelial defect heals, and BCL can be used to help to promote the healing. So there are several surgical options available. Anterior stromal puncture is typically used for lesions that do not involve the central axis. So the punctures are made through Bowman's membrane, and this helps to promote firmer adhesions. Superficial keratectomy can be combined with this or with diamond burr, and the diamond burr has been shown to reduce recurrence by creating a smoother Bowman's membrane. And PTK is typically reserved for more severe cases, so it tends to remove just the anterior part of the stroma. In terms of complications, corneal haze can occur with deeper ablation, as we talked about, and this has been reported in up to 40% of eyes after diamond burr. Majority of these cases are not visually significant and improves by 6 months. Refractive change can also occur typically after PTK, and this can be hyperopic, myopic, or changes in astigmatism depending on where the ablation is. Recurrence of recurring corneal erosions can occur in up to 40% of these patients after the procedure, and this tends to be the lowest of PTK and diamond burr. So we started looking at our results in Toronto as well. So since 2006, we have performed surgical procedures for 126 eyes with recurring corneal erosions. And you can see that the highest recurrence rate occurred in the group with anterior stromal puncture, and the lowest was with diamond burr. And just to note that the PTK group did have a slightly higher recurrence rate, but these patients also had severe disease. So in summary, corneal haze can occur after diamond burr and PTK. Majority of these cases are not visually significant, but we presented a case of patient with severe haze that did require further procedures. And hyperopic shift can occur after PTK and should be discussed with patients. Thank you.
Thank you, Yellen. That was excellent. Any comments, Guillermo?
Nope, really good review. I think there's so many options, and the patients come in a lot of pain. Usually, I mean, it's a very stressful situation for them. It's funny that I just had one patient right now, and the first time I just sort of debrided a little bit, and today I did the Amoyal's brush, and I sort of explained to them how we have to manage the ocular surface and how we go step by step. But one thing that I have found helps in terms of working through the different options is to tell them that, you know, call me when it happens, and you're not going to live like this for the rest of your life. So it may take us a while. It may be one treatment. It may be 3 treatments, but we're going to do all our best in terms of making sure that you are fine. I have found very good useful in terms of using, as I mentioned before, the management of ocular surface, as well as doxycycline as well. There's a couple of studies where that helps reducing, from a medical point of view, the recurrent erosions.
I like narrow 128 nightly. Tanya, do you have a photo of those 2 corneal burrs?
Unfortunately, they didn't turn out quite as well because the magnification was too small.
Okay.
Yeah.
I think it's important to differentiate the different corneal burrs that we have. You know, there's one, I've had this problem with a corneal burr a long time ago, many years ago, where if you use the small burr, you're actually removing tissue. The one I like to use, and the one I know that Chris Rapuano uses as well, and I think he was the first to describe diamond dusted application and superficial keratectomy, is a 5 millimeter diamond dusted burr. And you just apply it gently to the surface of the cornea after you've done your super K to get rid of all the redundant basement membrane. And if you do that carefully, I have not seen any, and gently actually, I've not seen any episodes of flattening of the cornea, and I've not seen any episode of scarring. So I think that that's one little pearl. Be careful of the burr that you do use to flatten the cornea.
Yeah, I agree, Alan. That's a really good point. It has to be gentle, and it does work, but it has to be gentle.
Yeah. Do any of the cornea faculty want to add anything further before we move on to our next case?
Just had a question.
Use of the diamond burr. So I'm not a big fan. The other thing is I haven't had good success with tetracycline or doxycycline. So.
Yeah, I see on the chat we have a couple comments. You know, Omar Hakim is saying that tetracycline and mild steroids can be helpful, which certainly I think Guillermo is talking about. I used to, I think maybe most of us, maybe I was just foolish. I used to start everyone on Muro or lubrication, see them in 6 months. If they didn't get better, then I did 2 months of FML BID or Lotamax, and then with oral doxycycline for 2 months to see if that worked. That was based on the studies that showed the decrease in MMP9s and that those probably inhibit the hemidesmosome reformation. And I actually found that it really didn't, if they didn't heal with nothing, I found that those in and of themselves didn't help much either. So I sort of changed my management. And now what I do is I say, I'll try lubrication. And if lubrication works, fantastic, that's it. And if it doesn't work, I hit them with everything, which is a superficial keratectomy, a diamond burr. I do stromal micropuncture if it's outside of the central area, or if it's from a trauma, usually not if it's EBMD, because you know it's a limbus to limbus problem. And I do the doxycycline and the steroid at that time. And the last thing I do is I keep the BCL on. I used to keep it on for 2 weeks. Now I keep it on for 6 weeks. So I say basically you get tears or you get everything at once, because I don't want to ever go back. And I find that sort of bazooka approach has been really good, and very few people fail that.
You know, the one thing I also want to point out is that, especially with basement membrane dystrophy, you know, you can sometimes they come in and you can actually see, often you see nothing except basement membrane dystrophy, but sometimes you actually see the area of the erosion. You know, if you're going to do anything, whether it's stromal puncture or debridement, I recommend you need to go certainly beyond the area of what you see with the erosion, because there's loose attachment of epithelium that goes out quite peripherally, and you really need to include that in your debridement and your superficial keratectomy. And sometimes what I'll do is I'll add a little bit of if I think it's still loosely adherent and I don't want to go out any further, I will add a little bit of anterior stromal puncture out to the periphery of the of where I've debrided. The other thing is that I think when they come in, you know, usually I'll give them a trial of Muro 128 nightly. I think that's more important than lubricants during the day, because, you know, the eye becomes hypotonic, the epithelium swells, and when you open your eyes, it just pulls off a piece of epithelium, and then you have your recurrent erosion. So, you know, I'll try the Muro 128, and then I move quite aggressively to doing a superficial K. I think patients appreciate the fact that they're in pain. You're not going to, you know, you're already, rather than waiting till they're healed and doing, you know, doing a debridement afterwards, I like to just try to do it at the same time if possible and deal with it. And I think the uptake from patients has been very positive. The other thing is if I'm going to do a PTK, then I've got to book it, and there's an added cost. When I do just a superficial K, if we have the time, a lot of times we'll just do it that day in the office. And it can even be done at the slit lamp.
So a couple questions here before we move on to the next case. The first is just a rapid fire question. I'll send this to Josh Teichman. What is the dosage that you use for doxycycline?
I use 50 milligrams a day. It can be hard to actually get that number. So what I tell them is to get the 100 milligram tablet and split them in half. You can use, and the reason is the 100 milligram tablet is the cheapest. Aprolon is a 40 milligram tablet, which is 30 milligrams of, like, I believe it's immediate intense sustained or vice versa, either way. But Aprolon's very expensive. And then the last one is you can use like Periostat, which would be 40 or 20 times 2. But again, Periostat's expensive. So I just take the 100 milligram doxycycline tablet, tell them to break it in 2. And if they can't, because sometimes they are unable to, I tell them just take 100 every other day, which is close enough, because it saves them a lot of money. So that's my dosage for that.
Perfect. Thank you. And then there's one more question, and we'll open it up to all the panelists. For Millie Roy, is doxycycline effective primarily in the subset of patients with underlying meibomian gland disease, or is it for the entire group? I don't know if anyone wants to tackle that one.
Well, I was just talking about doxycycline, so I'll answer. I think that obviously it helps with the meibomian gland dysfunction, but and with meibomian gland dysfunction, of course, they have yet another reason to have issues. But the actual mechanism of action is supposed to be the reduction of MMP9s, which are inhibiting better hemidesmosome formation.
Okay, so let's move on to the next case. Thank you guys for the input there. So Amrit, go ahead.
Thank you. Great case, Yellen. This case that we're going to talk about today is a 59-year-old female who was referred for bilateral cataract surgery. Her visual acuity was 20/150 in each eye. And for the purpose of this talk, we're going to focus primarily on the right eye. So the patient had an eye wall master, which shows 1.7 diopters. I think you can see my cursor there, with the rule of astigmatism in the right eye, and 0.64 diopters of with the rule of astigmatism in the left eye. So a significant difference between the two eyes. We also see the topography of both eyes given here. And I want you to keep the appearance of the topography in mind as we go through the next couple of slides. Zooming in on the right eye topography, we see that there's 2.07 diopters at axis 79, and we'll launch our first poll here.
Okay, so that's up. So we'll let it run for.
I think this
seconds.
may be from the other talk.
Oh, I'm sorry. I'm sorry. Yeah.
No, not this one either. It should be, what is this topography most consistent with?
Let's see. Yep. Okay.
There you go. Okay, so very good. Most people got the correct answer of pterygium. And you can see that there's relative flattening in the nasal quadrant. And then, I mean, it's important to know, why is the topographer saying hyperopic refractive surgery? And that's because this nasal flattening makes the other 3/4 of the cornea appear relatively steep, similar to what we would have seen in post-hyperopic refractive surgery patient. And we need to be aware of this, because if you run a post-hyperopic refractive surgery formula to determine your IOL, you're going to get a significantly different answer. You're going to end up with a hyperopic surprise. And so the first pearl I want to share is don't always trust the machine's analysis. And again, looking at the left eye topography, we see that there's a small amount of with the rule astigmatism. We see a much more regular appearance here. And of course, we can confirm our diagnosis by simply examining the patient. You can see a moderately sized nasal pterygium. The patient also has visually significant cataracts, resulting in a vision of 20/150. And when we discussed the option of cataract surgery, the patient told us that she wants to have spectacle independence after surgery. So at this point, we'll launch our second poll to see what we would offer this patient in our clinical practice.
So this one's pretty lopsided, so I'll just end it here and share the results.
So that's also what we felt. So the decision depends on the size and the location of the pterygium, as well as the effect that it's having on the corneal surface. If the pterygium is large and induces a lot of astigmatism, then it should be operated on first. Active, elevated, or inflamed pterygia are the most likely to cause corneal changes. Small, inactive pterygia can be ignored. If the pterygium is small and it doesn't seem to be affecting the corneal topography, then a combined surgery is also an option to save the patient from an additional surgery. However, if you decide to do that, you should not use a toric lens in those cases because you don't know how much the astigmatism will change after the pterygium is removed. If you went ahead and you put a toric lens here and then remove the pterygium later, you'd end up with pseudophakic astigmatism, which can be difficult to manage. You'd have to be confident that the patient won't want or need pterygium surgery in the future to go down this path. If we decided to proceed with cataract surgery without removing the pterygium first, the Barrett toric calculator is suggesting putting in a 23 diopter T3 toric at axis 78. However, like most of the audience, we decided to do the pterygium surgery first because we felt that it was having a significant effect on the corneal astigmatism. Then we went on to do cataract surgery in the left eye to allow more time between the right eye pterygium and cataract surgery. And finally, we did the cataract surgery 4 months after the pterygium was removed. And maybe one of the panelists can comment here on how long they usually wait between pterygium removal and cataract surgery.
I usually wait 2 months, and I like to get some sort of do 2 measurements showing that there's not much change between the 2 visits.
Do you ever offer simultaneous surgery?
I did many, many years ago, not anymore. I think it's hard to predict exactly how much that, I mean, if it's really small, less than 1 millimeter, yes, but yours was significantly more. It looked like about 2.5 millimeters onto cornea. And the other thing is, you know, just because there's not a lot of astigmatism with the rule, I mean, I've seen the axis flip after you've removed the pterygium. I actually pulled a slide, which I'll show a little bit later on if there's time, where there's a significant reduction in astigmatism following pterygium excision. Guillermo, what about you?
Yeah, no, I agree. I've always removed the pterygium first. I think in the age of refractive cataract surgery, that's a no-brainer. I usually wait at least 1.5 months. And once I get a reliable topography as well as a reliable biometry, then I simply go ahead and book the patient. And it's usually between 6 weeks and 8 weeks.
Nira, what about you?
Yeah, I agree. But I think, you know, everything is the clinical perspective. So this patient came in and she wanted to be spectacle free. So these are the cases I think it's really, really important to be adamant that if in that situation, we have to remove the pterygium first. But, you know, being in Toronto, especially downtown with a fairly diverse population, sometimes you get patients that don't mind wearing glasses. And, you know, depending on how visually significant their cataract is and how much it's affecting their activity of daily living, I have made exceptions where the patients say, you know what, I'm happy to wear glasses. I will do both surgeries at once just to save that patient from having 2 surgeries. But I mean, the right thing in the patient that wants to be spectacle free is definitely proceeding with the pterygium removal first. I typically wait 6 weeks. If you do the cataract surgery too soon, number one, as other people have mentioned, the surface may not be stable and you may not get reliable measurements, but also there is a higher risk of recurrence of the pterygium.
Yeah. Now, the other thing is if you're doing cataract and pterygium surgery, you're probably not doing a conjunctival autograft. At least I didn't many, many years ago when I was doing them both together. And I think we know the incidence of recurrence. You know, my own data shows that it's less than about 2% with a conjunctival autograft for primary pterygium, whereas without a conj graft, it can go up to 50, 60% recurrence. So I think, you know, for that reason, it also makes sense to get rid of the pterygium properly and then do the cataract. But I agree with you. Some patients do push you. They want to get one surgery. They want to get it corrected. They're not seeing well, and your hand's twisted a little bit. Amrit, why don't you proceed?
Excellent, thank you. So we decided to look back at our biometry and see how much of a difference the pterygium made. On the left, we have the pre-pterygium surgery biometry. On the right, we have the repeat biometry after the pterygium was removed. And so now the IOL master is measuring 1.57 diopters of width the rule astigmatism at axis 94. And so while the magnitude has minimally decreased, the axis has rotated by 12 degrees, which can be quite significant. We repeated the topography as well, and it's now measuring 1 diopter of astigmatism at axis 89. And again, if we recall, the pre-pterygium astigmatism was 2 diopters at axis 79. So again, we have a reduction in the amount of cylinder, this time by a whole diopter, and the axis has rotated by 10 degrees counterclockwise. And so pearl number 2 is that both the magnitude and the axis can change after the pterygium surgery. And you can see that while the topographer is no longer calling this a post-hyperopic refractive surgery patient, it's still not confident in its classification. Here we have the pre and post-pterygium surgery topography, and we can see that while there is still some nasal flattening, we can start to make out more of a regular with the rule bow tie appearance in the astigmatism. We repeated the Barrett toric calculator, and it is now suggesting a 22 diopter T2 axis 96. And so here we can now compare the suggested IOL printouts from before and after the pterygium surgery. And there's 3 things that I want to point out here. After removing the pterygium, the magnitude of the corneal astigmatism decreased, which means we can use a lower powered toric. But this part was fairly predictable. I think most people would have expected this change. The axis is rotated by 18 degrees from 78 to 96, and this is quite significant. If we recall, a toric lens loses about 3% of its toricity for every degree that it is off the correct axis. So at 18 degrees, you lose 54%. And third, most surprising, is that in addition to the cylinder change, there's also a significant change to the spherical equivalent. The new lens is a whole diopter less powerful than the previously predicted IOL. This means that removing the pterygium made the overall cornea steeper, and had we placed a 23 diopter IOL in this patient, they would have ended up with a myopic result. And in case you're wondering, we chose to use the T2 in this case instead of the T3 for multiple reasons. One, because our topography was measuring less astigmatism than our biometry, which was used to make these calculations. The T2 maintains the axis with the rule instead of flipping the axis. And lastly, this patient is young. She's 59 years old, so she'll likely develop some more against the rule astigmatism as she ages. So it's better to leave her with some with the rule astigmatism now. At 1 month post-op, the patient was seeing 20/20 in both eyes without correction, as was our target. And the pterygium site had healed well, and the patient was very happy with her outcome. There have been quite a few studies that have looked at the effect of pterygia on corneal topography, including a recently published paper by one of our own cornea fellows at the University of Toronto, Dr. Nir Sorkin. We can see that flat keratometry and mean keratometry both steepen. Both anterior and posterior corneal astigmatism decrease. Posterior corneal astigmatism becomes more with the rule. And as we saw in our case, pterygium removal can lead to a myopic shift consistent with that mean keratometry steepening. And generally, pterygia less than 2 millimeters are less likely to cause a topographic change. The key point is that we know that pterygia have a relative flattening effect locally, and that removal of the pterygium steepens the keratometry. But what we are not confident in is is to predict how much that will change. And so it is generally recommended that if it seems likely that the patient will need to have the pterygium removed in the future, then it is better to do that prior to cataract surgery, as most of our panelists commented. Thank you.
Excellent presentation, Amrit. I know Amandeep has got a question to the panelists, but I just wanted to an impression. Looking at that pterygium, I was surprised at the, that how little it impacted the astigmatism. I mean, it's changed the shape or the axis and reduced it by like, what, 0.2 diopters. I would have thought easily it would have been a full 2 diopters. Did you get all of the pterygium? Was there anything, were there like any Salzman's type nodules, anything after that, or?
No, the pterygium came off fairly easily, and the IOL master measured 0.2, whereas our topography we saw. Sorry, I don't have the comparison here, but the original had 2 diopters, and after the pterygium was removed, it was 1 diopter. So they're both sort of measuring a different amount. We saw more of a reduction in the topography measurement.
Your points were excellent and well taken. I'm just saying that I would have expected, looking at that pterygium clinically, that you would have had a little bit more of a reduction in the astigmatism.
Amrit, I have a comment. If you stay on that slide, the machine is interpreting it as keratoconus suspect. I'd like you to focus on cornea spherical aberration and corneal asphericity, and then go to your first topography that you showed. The very first one, where it was interpreting it as a hyperopic refractive surgery right there. And so if you look at the spherical aberration, it normally is 0.27. After hyperopic ablations, that spherical aberration is decreased. So that corresponds to the 0.136. Corneal asphericity, normal, is around minus 0.27. And after hyperopic ablations, it goes down. So it's interesting how this effect of the pterygium affected those 2 parameters, which is what sort of was the confounding effect on the machine's interpretation of the aberrometries.
That's
an
an excellent point.
And to the point of Dr. Slomovic, who was saying that they would have expected the amount of cylinder to be reduced by more, and on the topography it was. I think when you have abnormal corneas, the topography is much more accurate than the IOL master. And I'm not sure which IOL master version you were using, but certainly if it was a 500, you'll have like 6 corneal points, which are not sufficient in an abnormal cornea. If it was a 700, then obviously it has a lot more points. But even still, I think that can really factor into what you're seeing. And that actually makes it challenging because I usually go with the IOL master for the magnitude for most of my toric IOLs, and I use my topography for my axis. However, in a case like this, I don't know which I would choose for the magnitude.
I think Josh's point is really valid. If Amrit goes back to his biometry slides there, the pre-pterygium biometry appears to be an IOL master 500, and the post pterygium biometry is an IOL master 700. So that is exactly to Josh's point. While the topography is consistent, it's the same machine before and after. There is a question here from the audience. If SIL is less than 1.5 diopters, can we do both together? And we'll toss this out to Neera, but Amrit has already illustrated that it's not just the astigmatism that is affected here, but even the spherical equivalent can be affected. But I don't know if we have any thoughts on just the cylinder aspect of things. We'll ask Neera and Josh about their thoughts.
I mean, I think that, in terms of cornea refractive, anything above 1, I consider significant. So if I see that, I'm much more inclined to remove the pterygium first and try to get the cornea as spherical as I can. I think, based on, I can't remember what the topography Ks were like, but in general, I typically will go with those as opposed to the IOL master when I'm doing my toric IOL calculation post pterygium surgery. So I would say, if anything is in the range of 0.5, 0.75, maybe then I would consider doing both together. But again, I'd like to look at the amount of irregularity it's causing on the placido discs.
And I don't know if any of the other panelists have any thoughts on that as well. Okay. So let's move on to the next case. Are we going to do?
Amandeep, in view of the time, I think we're going to go right. I'll introduce Dr. Rocha, and we'll go into his talk. So
Sure.
this time at the end, we'll present the last case. Okay, so it gives me great pleasure to introduce someone who really needs no introduction in Canadian ophthalmology, Dr. Guillermo Rocha, who is our visiting professor today. I think before we started, Guillermo has mentioned that he's visited at least 3 or 4 different continents in the past week without leaving the comfort of his home. So thank you, Guillermo, for coming here today. Dr. Rocha is originally from Mexico City, Mexico. He did his residency training at McGill University and completed subspecialty training in ocular immunology and inflammation at McGill. He did his fellowship in cornea and external diseases at the University of South Florida in Tampa. He also, interesting, many of you probably don't know this, he completed the Physician CEO Executive Program at the Kellogg School of Management at Northwestern University in Chicago in 2016. He is a full professor of ophthalmology at the University of Manitoba. And I want to just share the screen with you for a moment. Can you see that?
Yes.
So I think they're calling me to the OR. He's past president of the Canadian Ophthalmological Society, and this was welcoming him in as I was leaving, as he was president of the Canadian Ophthalmological Society, and this is when I was just welcoming him into being president. He is head of the Department of Surgery, former head of the Department of Surgery at Brandon Regional Center, past associate editor and cornea section editor for International Journal Techniques in Ophthalmology, and co-editor of 4 books in cornea and anterior segment surgery, past chair of the Council on Continuing Professional Development for the Canadian Ophthalmological Society. He was also the recipient of the Lieutenant Governor of Manitoba Eye Care Award in 2014 and named as one of the 10 most influential Hispanic Canadians in 2016. Dr. Rocha currently resides in Brandon, Manitoba. He's medical director of TLC Laser Eye Center in Winnipeg, medical director of the Ocular Microsurgery and Laser Center, and active staff in the Brandon Regional Health Center. We're very fortunate that we have Dr. Guillermo here today, and he's going to speak to us on tips and tricks in the management of pterygium. Dr. Rocha?
Well, thank you. Thank you very much, Alan. I'll go up with my screen. It's really a pleasure to be here. As you were saying, yeah, I started the week in Mexico. I was in Costa Rica yesterday, actually with David Rootman and Gisela, who I see. And it's really great to be back in Toronto, so to speak. The last time I was there was in the middle of winter, so it's nice to have me back here when the weather is so much nicer. Of course, I miss the good dinners that we usually have in these presentations. It's great to see some familiar names as well. And what I'd like to talk to you about is some tips and tricks in the surgical management of pterygium. Now, this pandemic has affected us in a number of different ways. My daughter lives in London, and she's been in lockdown for the past several weeks, if not months, and she managed to go out and donate some blood, and she took this picture of Oxford Circus, smack in the middle of the day, smack in the middle of London. So this is kind of like an apocalyptic scene. But at the same time, I think it's been a time to reconnect, and I thank you, Alan, for the invitation. I also would like to thank Amrit's older brother, I can't remember his name, for organizing this. Just kidding, Amandeep. And we'll get started. So this is a case that I did as an emergency pterygium surgery during the pandemic. I wanted to start with that. And I hope people are paying attention because, of course, I shouldn't have done anything in the middle of the pandemic related to pterygium, right? So this is just it's kind of a bit of a joke. There's no video, of course. We should not be doing pterygium surgery in the middle. These are all elective cases. What I hope to provide at the end of the session is to describe surgical techniques to minimize recurrence, select the appropriate dose of the use of mitomycin, and understand the management options in recurrences. To get started, for significant primary pterygium, what is your preferred approach? And Amandeep, I wonder if you could launch the poll. Vasoconstrictors and steroids, excision, bare sclera, mitomycin C, excision plus rotational graft, and we can see here that it's building up.
Oh,
Excise
starting to
plus
get some
aminobutyrin.
results.
Yeah, you're starting to get some results.
There you go.
Okay, so I see that the majority responded with excise and free conjunctival autograft. There's still some people who favor rotational graft and bare sclera with mitomycin C. So we'll discuss that. So we'll keep moving. All right, a little bit of a word on the pterygium. There's the body of the pterygium, the head of the pterygium, closer to the cornea, then the cap, which is the grayish zone. And when iron deposits in the irregularity at the leading edge, then that's called Stalker's line. This kind of goes well with the case that Amrit showed. And you can see here a pre-op topography with significant distortion, significant with the rule astigmatism, but very irregular cornea, and after pterygium removal on the right-hand side. So this is the approach that should be used before cataract surgery. And here I had a similar effect. You can see that there's a significant change in the lens power because of that myopic effect that Amrit was mentioning. Now, pterygium comes from the Greek for wing, and you can see the shape of the wing there, and that's where the pterygoid and the pterodactyl comes from as well. In terms of epidemiology, we see it more often in the tropics in response to sun, dust, wind, and pollution. So a simple way of preventing this is just wearing sunglasses with wraparounds. Interestingly, it presents basically only in humans. There's a lot of stimulus that goes from that stimulus from the ultraviolet light that affects the limbal stem cells. There's altered immunology as well. You see here the typical interleukins like IL-6, and IL-6 is one of the key ones here in the cytokine storm that we're seeing with the COVID-19 process, as well as other factors that lead to inflammation, epithelial proliferation, fibrovascular proliferation, dissolution of Bowman's layer as well. And then with that comes pterygium invasion with elastic degeneration of the conjunctiva. Interestingly, well, here you have the temporal aspect of the cornea. Some people have even reported or presumed that perhaps there's a kind of a fiber optic transmission through the thickness of the cornea all the way to the nasal aspect that leads to other changes in addition to pterygium, which may lead to preneoplastic lesions such as PAM or nevus, and then on the way to melanoma as well as ocular surface squamous neoplasia. So be cognizant of this fact. Make sure that all pterygiums are sent for histopathology. I can't say that I have gotten back any pterygiums with positive, but then again, perhaps the pathologists are not so in tune with looking for these things. These little nests are called Fuchs flecks, and you can see them, and they're kind of like nests of limbal stem cells that sort of have migrated there. The role of them or their presence is really not perfectly clear, but this is another clinical feature that suggests all the changes that are happening. Now, we're all itching to get back to surgery, and I think we're all almost zoomed out by this time with so much information that we're getting. I was happy that yesterday was my first surgical day back, and so I'd like to focus just on 3 things so that when the time comes, when you start going back, at least you'll have these 3 things to sort of refer to when it comes to pterygium. So I'll briefly talk about surgical tips, mitomycin C, and what happens with the recurrence. And in terms of surgical tips, I think the biggest discussions happen when we're talking about excision, graft dissection, and the repair process. During the excision, I like to minimize bleeding. And so while I always inject 2% xylocaine with epinephrine into the body of the pterygium, I have also found that apraclonidine just before surgery will help us constrict the blood vessels as well. In these cases, I like to use polishing with a diamond burr and then excise Tenon's capsules in actually quite generous way. So this is a case just before starting, and then after a drop, with apraclonidine there. You can see the blanching, so less blood vessels, minimal bleeding after that. And then after that, I will still put the xylocaine with epinephrine. In terms of the excision as well, there's a number of techniques. I have preferred over the past several years just to avulse it. I think it leaves a cleaner area just with a Q-tip on one hand and a firm grasp of the head and the cap of the pterygium on the other hand. I think that allows us then to have a cleaner excision. I do use a diamond burr. This is actually one of the orthopedic burrs, and it's a 5 millimeter burr, and always use it with water. Always use it gently, and I try not to go to the center of the cornea, but really just sort of polishing the limbal area and just the area where there could be any excrescences of the tissue that is left behind. In terms of graft dissection as well, I actually learned this approach, and I see Gisela is here, but I visited the Barracare Clinic back in 1989 or somewhere in 1990, and there was a Dr. Federico Serrano, who's a plastics guy, but he is the one who actually, even before the technique was described in 1985 by Dr. Ken Kenyon, he was doing, and I think he's the originator of this conjunctival autograft technique. And so what I like to do is just mark the area, use a crescent knife to cut two kind of pillars. And then I'll show you in the next video, once you have done the crescent cuts, find a very fine plane, take the Westcott, ask the patient to look down, and then go all the way through and just let the blades of the scissors splay open as far as they go. It's not gonna rip, but you've got your graft right there. And so then you just find the exact same plane, ask the patient to look down like he did right there, and then just cut the graft, and basically the graft is there. And so I found this a very, very easy technique and a very quick approach. Let me advance this there. Then the key is, and this is where some discussion can happen, do we just need a conjunctival graft, or should we dissect anteriorly more into the limbal stem cells and get a free conjunctival limbal autograft? And that is my preference. I actually like to go a little bit ahead past the gray line, and so that I have a very fine transplant. And then you cut it off, and we put it off in the area where we've resected sclera and we've removed tenons in a generous way. Now, I used to use sutures for the longest time, but soon after moving to Canada, I started using Tocil, which basically eliminates the needs for sutures. So we're basically focusing in the coagulation cascade, and we're using the benefits of thrombin and fibrinogen to convert that into a fibrin polymer and finally a fibrin clot. And so this is basically taking advantage of the biological glue. I like to use it still in a separate way. So sometimes you can combine it, but I prefer to use each component separately. And then it's simply cut and paste. I imagine many people have been doing a lot of cut and pasting in these past few weeks. And so then you basically bring the borders and you coap the borders to bring them close. And you can bring them close, or you can tuck it down. I think my preference now has been to sort of tuck it down and just sort of coap the borders peripherally, and then close the donor site in a similar way as well. And then that allows us to have a nice area where it's healed, and the pterygium has usually wait about at least 2 to 3 minutes for the glue to start working properly. Okay. So there can be technical problems. There can be possibility of dislocations. At the beginning, I would put sutures, but now I don't ever use sutures for pterygium surgery. There can be more edema when you use fibrin glue because there's less fluid that egresses through the sutures or in between the sutures. But at any rate, even soon after, you can see this kind of yellowish tinge, kind of like the serum repopulation or accumulation of some of the serum there. But the healing, even early on, can be quite nice. Another important point is to leave this area a little bit open. Don't encroach it on the cornea, because that can form, as it thickens, it may form adelin. And just after a few days, you can barely see the area where the pterygium graft was placed. Now, this is courtesy of Satish Srinivasan, he was also a fellow there, and I think he did this while he was a fellow in Toronto, and you can see the evolution very nicely healed. Now, what about mitomycin C? So it's an alkylating agent which inhibits DNA synthesis, and we're basically using it to prevent the fibrosis and the recurrence. So if it works so well, what is the concern? And I'll review a few of the uses. So the concern is that it can cause a lot of damage if used inappropriately. And so this is a bare sclera technique followed by mitomycin drops, and you can get scleromalacia, you can get corneal melts and perforations and very irregular corneas as well. These are dangerous things. You can get persistent Delin, you can get scleromalacia like you see here, just by leaving the bare sclera and using mitomycin C. You can also get significant limbal stem cell deficiency, and this is courtesy of Alex Lichtinger, who many of you know as well. And you see the irregular epithelium here on fluorescein staining and lissamine green staining as well, and problems with impression cytology. Now, one can use it preoperatively, intraoperatively, or postoperatively. So preoperatively has been described by Donenfeld as a subconjunctival injection prior to the excision of pterygium and leaving the area as a bare sclera. Intraoperatively is probably the most widely used with different concentrations, 0.01% to 0.02. You can apply the pledgets before or after excision and with different times. This is my preferred method, 0.02, pledgets after the excision, tucked in close to the, underneath the conjunctiva for about a minute with profuse irrigation with balanced salt solution as well. And I only use it in recurrences or in individuals who are darkly pigmented. So in primary pterygium or even in recurrences that were not from a free conjunctival graft, I will not necessarily use it. Now, there's a few studies, and one is also from Toronto, as you can see right there in the middle one, with the different degrees of toxicity and endothelial damage. And that's why I've gone down to the 0.02%, around 1 minute with minimal or no toxicity reported. A few years ago, during my fellowship, I had the opportunity to work on a meta-analysis with a colleague of mine as well. And so basically the conclusion is that we should not leave the sclera bare. There's a higher risk of recurrence, up to 25 times more. It does work well if you combine it with mitomycin C, but you have the potential problems that we mentioned before. So conjunctival autograft is really the preferred approach. Now, should we just use the free conjunctival autograft, or should we include the limbus? So in this particular study, they said it's probably about the same for both primary and recurrent pterygia. You do see a few more cases here in the free conjunctival graft versus the limbal one. And I still think that if the limbal cells are there and we've affected those in the limbal area nasally, why not put them there? So that could be a question for discussion. So what happens if it came back? So we've talked about surgical tips, we've talked about mitomycin, and so after all that, it came back. So Amandeep, can you run this poll for the recurrent pterygium? So what is your preferred approach if it comes back? Vasoconstrictors or steroids, excision plus free conjunctival graft, amniotic membrane, refer?
All right, we'll let it go a couple more seconds there before I call it.
Okay.
It's pretty split here. I'll share the results with you guys.
Mm-hmm. All right. So it seems like excision again with amniotic membrane or referral, I guess. So we'll keep going and we'll see where we are perhaps for the discussion. I think an important thing when you're looking at a recurrent technique is, was it your own case? And in that case, well, you obviously know what the original technique was, or was it somebody else's case? And you do need to know what the original technique was. Then we'll look at some non-surgical options and reoperation. So if the original technique was bare sclera alone, or bare sclera plus mitomycin, or a rotational graft, to me, that's an easy answer. That's a free conjunctival autograft with full excision of the pterygium. Now, if we had free conj autograft or amniotic membrane transplant in the first time, then we need to sort of address this in a bit of a different way. You have to review the original technique. Once again, this is from Satish's presentation. And you can see here that early on in this case, the pterygium was displaced, even though glue was used. And here you see that. But it was easily repositioned and it was easily adapted. If you have a transplant like that, that moves and nothing is done, then there's a higher chance of it becoming fibrotic and having a recurrence. Now, other non-surgical options include 5-FU subconjunctivally, the use of Avastin, and there have been some reports. I have used Avastin in a couple of situations, and I have not particularly been very impressed with it in terms of preventing. Maybe it controls. Avastin, we know, may work in acute new vessels, not in the ones that have been well established. But it's sort of tempting to do something short of taking the patients to the operating room. Now, interestingly, there is the possibility of using mitomycin C, sort of when we use it for neoplasia, 1 week on, 1 week off, 1 week on. And so that seems to help even 3 to 5 months after surgery in the management from a medical point of view of pterygium, of recurrent pterygium. Now, in my opinion, these 3 cases, Behr sclera, rotational grafts, and plus minus mitomycin should need a free conjunctival graft. So that's kind of an easy option because you're sort of the savior. You say, okay, that's what was done the first time. Now we'll do this technique. And I may or may not use mitomycin. Most likely I would not in that recurrent pterygium if the original technique was as described. Now, in these other, I will still consider, as was the result in the poll, a free conjunctival autograft, or if I don't have enough tissue, I may consider amniotic membrane transplant. An amniotic membrane is very tempting to use even in the primary pterygiums, but the reports on the literature invariably show that it is better to use a free conjunctival autograft as compared to the amniotic membrane, even though it might be a bit easier, because the recurrence rate seems to be slightly higher with the amniotic membrane. And I'll just put it here. And the technique is very similar. Once again, putting the fibrin glue and then just sort of tucking it underneath the conjunctiva. There. So this is how amniotic membrane transplant looks at 2 weeks. It's beginning to sort of vascularize and it begins to look good. So in terms of approaches, to summarize, there can be Behr sclera plus mitomycin. Yeah, it's simple, but there's high recurrence and high risk of complications. You can do a rotational graft plus minus mitomycin. It's quick and easy, but the cosmesis is not as good. So my preferred approach is really the free conjunctival and preferably limbal autograft in certain times if combined with amniotic membrane, if it's 2 pterygia, and it's excellent for results. It does require more time and more skill, but it is a better option for the patient. Now, expanding a little bit on that, Laurie Hurst from Australia has advocated the pterygium extended removal followed by extended conjunctival transplant. So that's sort of all the letters for perfect. And he does a fairly large excision, fairly large subtenon excision, and a very large graft, as you can see here, up to 13 millimeters. I normally use 6x6 or 7x7. So he's basically double that, reporting a 0 recurrence rate. So that's another approach. And then what about this? In some cases where the limbal cells have been affected significantly, one can use SLET, or simple limbal epithelial transplant, where you take a small piece from the donor eye or the same eye, then you mince it into little pieces and place it over an amniotic membrane. And this is one of my cases, not for pterygium, for a different situation. And you can see all the little pieces there glued also with the fibrin glue. And thank you, Tanya. I know you're here on the panel list, but this is a case that she sent me from Toronto as well, where they basically took the specimen from right here. And this is the reconstruction that was achieved by using a simple limbal epithelial transplant with amniotic membrane and mitomycin C as well. So a pretty impressive result. So in summary, we've talked about surgical tips. What about mitomycin C and recurrence issues? The best approach, in my opinion, is to do a proper polishing, excision of the Tenon's capsule, but also proper polishing of the limbal area. Use always a free conjunctival limbal autograft, although a conjunctival graft is also adequate. With that, you really reduce the rate of recurrence. And if you're facing a recurrence, either a repeat free conjunctival graft or amniotic membrane with mitomycin C, you could use the perfect approach from Dr. Hurst, or you could use SLET, depending on the amount of tissue availability that you have. Do not leave bare sclera. Use beta irradiation or mitomycin postoperatively. Just think of all those cases of scleromalacia and corneal perforation. And this is where I was last weekend, and I hope to be there every other weekend starting now, and I will maintain my isolation. Thank you very much.
Guillermo, thank you for that talk. Very informative and comprehensive as always. I always learn a lot from you. And despite the fact that you forgot my name, you've been both a great mentor to me and a friend over the last couple of years. It's really been a pleasure for me to get to know you. So in this time of COVID and the pandemic, I want to thank you for your friendship. I look forward to seeing you in person again. And it's been a pleasure seeing you online, both at our rounds and elsewhere in the last couple of months. So thank you for all the teaching you've been doing. I don't know if any of the panelists have any comments on their techniques or anything different to add on top of what Guillermo has already done.
I think one thing the Hurst technique, it makes me cringe when I see the perfect technique. And I know you and I feel similarly about that, Guillermo. Just calling it the perfect technique is a little bit presumptuous, but I think it's important. His concept of removing as much Tenon's tissue is good. The other thing is, I think, as you pointed out, our SLET patient with the bilateral, with the nasal and temporal pterygium, did have quite a bit of stem cell disease, had a prior conj graft that failed with mitomycin. So I think you have to do something different. I think SLET does offer some advantages, not in all patients though, is what we've been finding. Tanya and I are just publishing a series on that. The other thing is about mitomycin, I think it's the pterygium surgeon's friend, but clearly it's potent medication. I think if you leave mitomycin on bare sclera is where you're going to get into problems. And that's not where it's most helpful. You want to put it under your conjunctiva, which is where the fibroblasts are, because you want to affect those fibroblasts. And having done many, many, many mitomycin applications for pterygium, the only thing we've seen is that paper we published with ERIT where there was a reduction of endothelial cell counts. I've not seen any melts of the sclera, any infections when we've put it under the conjunctiva. I'd be interested in your point of view.
Yeah, no, I agree. I've used mitomycin for many years as well, and fortunately, I have not seen those issues. Having grown up in Mexico, I remember in Mexico, it was the pterygium surgery was the surgery for the first-year resident, and all we were expected to do was just sort of snip it off and, quick and easy, just close it up, and that was it. And I did see a lot of recurrences and a lot of issues with that. Back there was also, it was very popular to use beta irradiation as well. And we saw a lot of problems with that as well. And then fortunately, I started working with a surgeon who had actually trained in Bogota. And he's the one who taught me, even as a first-year resident, I would go to his office in the afternoons. And so I remember one time I went to the hospital where I did my first-year residency in Mexico. And there was a young lady with a pterygium, and they said, "Yeah, just snip it off." And I said, "Can I do the free conjunctival graft?" And I convinced them, and they said, "Well, it's too much time, it's too much work," but she did really well with that. So I think the key is everything, too much of something or too little of something, obviously that balance is what can hurt us. Mitomycin can work, and it works. I've never seen an issue with it, but I've always been very conservative in that respect.
I think the other thing you mentioned about the proclonidine and trying to get the pterygium to get rid of the injection. You know, I think the point about limiting the amount of cautery you apply is really important. I think the more cautery you apply, the more likely you're going to stimulate inflammation and perhaps precipitate recurrence. So you want to be gentle with the cautery.
Mm-hmm. Yeah, I think it's sometimes underestimated. You know, it's such a common thing in certain parts of the world, and here we have people from everywhere. I see here in Brandon, I see a lot of people from Central America, a lot of people from Mexico as well, and so they come in with big pterygia, and it's almost tempting, you know, when you have so many to sort of say, oh yeah, it's just let's just do a quick thing. I think pterygium, in my opinion, has to be meticulous. You have to sort of address all the issues. You have to control the bleeding, but not too much. You have to respect the limbal stem cells and the ocular surface. And then you're done. Because if you do it like that, I think the risk of recurrence is, as you were saying, Alan, very, very low. It's less than 2%, and even in recurrent pterygium. And when they come back and you do a good, careful job. So I think it's worth taking the time to do it well the first time around, because then it benefits everyone down the line. You're not dealing with these recurrences.
Well put. Couldn't put it any better. Anybody on the panel, any of the cornea faculty want to make any comments before we hand it over to Amandeep to thank Dr. Rocha?
There's a couple questions here. Maybe we'll do those. Kim and Jay Bodesing from Barbados is asking if there's any special considerations for MMC in darkly pigmented patients.
Guillermo?
I'll let somebody else. Well, yeah, I'm not sure if anybody else wants to do that. I sort of have a shorter threshold when I see darkly pigmented individuals, especially if there's a lot of pigment around the conjunctiva or the tenons is very, very thick. I'm just more concerned that there will be more chance of recurrence. I don't know what the experience has been from others.
If it's a flesh, much like you, if it's a fleshy. large pterygium, I think Donald Tan has shown that the chances of recurrence, he's graded them actually, and I think the chances of recurrence are greater. So like you, I usually don't apply mitomycin on a primary unless it's a really large pterygium and it's a very thick pterygium.
Yeah. Yeah, that's my approach as well. And then there's a question on the size of the pterygium. I normally use 6x6 as a routine, maybe 7x7, and then sort of try to bring in and tuck in the edges of the resected area close by. I've never used the perfect technique. I don't know if anybody else in the panel, Neera, you're nodding or something.
Yeah, no, I don't as well. I mean, I agree with everybody's points. I'm always worried about resecting too much. In fact, I like to just mark the head of the pterygium, and the amount of tissue resection that you actually have to remove is a lot less than what you think. So I think that's a really important thing to keep in mind. You know, you may think that there is a larger amount of the pterygium that you have to remove, but the reality is it's quite small. Even in the largest pterygium, it just retracts once you free up that head, which you so nicely showed in your video.
Do you agree with a good resection of tenons?
I agree with that.
Yeah.
So question for maybe Dr. Cheward and Dr. Rootman. With respect to patients who have glaucoma, do you ever alter your technique to either get an inferior graft or maybe start with an amniotic membrane in order to preserve the superior conj for the glaucoma surgeons?
For me, yeah, you can try a different location. I'd probably still use a conj-free graft if I can, just harvest it away from where the site would be. And even so, if you do a very good job with your harvesting your tissue, you should still have good conjunctiva afterwards, if indeed the person needs a tube shunt or a trab in the future.
Yeah, I'd agree with that. try and just be as sparing as you can of the conjunctiva.
Amandeep, we actually published on that with one of our former fellows, and we compared superior versus inferior grafts, and there was no difference in the complication rates or the recurrence rates. So it's probably advisable if the patient has glaucoma that may need a TRAB.
Okay, and there's another follow-up question about steroids. Do you keep, for darkly pigmented individuals, do you have a longer course of steroids or a higher dose to start with for these patients? And we'll throw that out to the whole panel.
Sometimes I'll give subtenon's Kenalog at the time. Of course, to monitor their pressure, that's a nice way to kind of give them some delivery. Obviously, if a patient has glaucoma or something else, you're worried about their pressures, I wouldn't. I've had to cut out, it does work well if you think you're getting steroid response, sometimes you can cut it out if you have to, and that helps. But I agree, I do keep them on longer and maybe a higher dose at the beginning if they're more darkly pigmented. And for younger.
Maybe we. Oh, sorry. Go ahead.
Sorry, and for younger individuals too, are those at higher risk for scarring or recurrence?
Thank you. And I think it's often useful for the audience to hear what is your for routine primary pterygium with routine autograft. What is your routine post-op drops regimen? And we can go around the panel here for that.
Just use a topical steroid 4 times a day, usually for about a week, and by that time it should be healed. Topical antibiotic, topical steroids 4 times a day for about 3 weeks, and then I give them a gel like tear gel or some kind of gentile gel at least 3 to 4 times a day for about 4 weeks, if not more. I tell them something magical happens after 2 weeks where all the redness, all the inflammation, everything all of a sudden just kind of settles down, and they'll feel much better after that.
It might be the patient population that we have in Mississauga and Brampton, but I use significantly more steroids than that. I actually use, so I do the antibiotic 4 times a day for a week as well. I do a BCL, and that's for a week. Artificial tears 4 times a day. I tell them for as long as they want, sunglasses forever. I use a strong steroid like prednisone. I use it usually 4 times a day. So what I normally actually do is just use Tobradex to make it easy, but a strong steroid 4 times a day, and I do that. I used to do it for a week, now I do it for a month. And then 1 month, I switch from a strong steroid to a weak steroid. So I go to FML or Lotamax, usually FML, because it's good surface acting. And I use that for another 2 months. So 1 month of strong steroid, 2 months of weak steroid. But again, our patient population have usually really bad pterygia, and they're generally darkly pigmented and generally seem to recur much more.
I'm similar to Josh. I keep them on steroids for about 3 months in total.
Much like Neera, I keep them on, I start them on Tobradex just to make it easy for the first week. By the end of the first week, we see them again, or roughly a week, 10 days. And then I switch them on to Maxidex. And I prefer Maxidex because it's brand as opposed to Predforte, which is generic. And you never know how much drug you're getting, how much steroid you're getting. And I start them on a very slow taper. Like I go 4 times a day for 2 weeks, 3 times a day for 2 weeks, and taper it every 2 weeks by 1 drop a day. And still I'm impressed by sometimes rebound. And I think it has to be tapered to the individual, especially in darker pigmented individuals. But I've been impressed by how long the eye can be red. And sometimes I end up bumping up the treatment and slowing it down again over time. So I think a long taper is a good idea.
Yeah, I do the same too. Thanks.
I just want to make a comment. There was a question about how large the pterygium should be for resection. I think, as you've heard, the post-op regimen is not benign. So these patients can be out of work for a week and they're on steroids for a long time. So I never remove pterygiums if the patients are not symptomatic. I mean, I think that goes without saying. So I don't go by size. I just base it on their clinical presentation.
it's a good point. I mean, every surgery has side effects and risks. And one of the things, I've seen many times is you should get a good history from the patient too, if they've had any previous surgeries before, if they have any rheumatologic disease and any risk for peripheral ulcerative keratitis. Sometimes you can see a pseudo-pterygium that appears and it looks like a pterygium. You're getting ready to do it and you take it off and all of a sudden it's a perforation. So you have to be very careful and make sure you have good slit lamp examination and good history of these patients too. And I'm very, I don't operate that often on pterygium surgeries or for pterygia. And if they're very minor, I just tend to leave them and be conservative. So.
Good.
Okay, excellent, guys. So thank you to the panelists for your contributions. Thank you to Amrit and Yellen for your great cases. And Guillermo, once again, thank you for a great talk. Your talks are always very informative and comprehensive. You really are a special mind in our field. So thank you for that. And thank you for your teaching and leadership. I want to remind everyone that the last grand rounds of the academic year will be next Friday, again at the noon time. And after that, grand rounds will take a pause for the summer and will resume in September back at the morning 7:30 a.m. Eastern time zone slot. So next Friday will be our final grand rounds of the year. We'll circulate the links to the normal channels. Thank you, everyone. Enjoy your weekend. It's nice in Toronto, so get some fresh air, physically distanced though, and take care.
Thanks, Amandeep.
Thank you, everyone as well, and thank you, Amandeep. I would never forget your name. I just wanted to. I'm sure Amrit has lived through his residency being Amandeep's little brother, right? So I wanted to do the opposite. All right.
Got it. Thank you.
It was great seeing you.
Thanks, Guillermo.
Likewise.
Thanks, a great talk.
Bye-bye.
Fantastic.
Thank you. Thanks
Bye.
for the invitation.